Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoy today's podcast.
Hello, I'm Dr. Craig Nunemaker, Associate Professor of Biomedical Sciences at Ohio University and member of Cardio's Team Best Practices. My research focuses on therapeutics that act on the insulin-producing beta cell to treat type 1 and type 2 diabetes. I'm here with Dr. Kathleen Dungan, Professor of Medicine and Endocrinologist at The Ohio State University, and co-lead for Cardio's Team Best Practices. Welcome, Kathleen.
Hi, Craig. It's wonderful to be here.
Well, as many of our listeners are aware, metformin has long been considered the initial treatment of choice for type 2 diabetes. Now, in this podcast, we will discuss why this may not always be the best option for some patients. Kathleen, what kind of evidence do we really have for the benefits of metformin in the first place?
The evidence for the use of metformin is really rooted in decades-old research dating back to the landmark United Kingdom Prospective Diabetes Study, or UKPDS. And in that study, recently diagnosed patients with type 2 diabetes were randomly assigned to intensive treatment, that is, with the use of a sulfonylurea if they were not overweight, or metformin if they were overweight, or to conventional treatment using therapeutic lifestyle changes alone in order to avoid symptomatic hyperglycemia. The intensive group had a 32% reduction in any diabetes-related endpoint, a 36% lower all-cause mortality, and 32% lower diabetes-related mortality. Those who were assigned to metformin had lower risk of any diabetes-related endpoint, all-cause mortality, and stroke compared to those receiving insulin or sulfonylurea. And they also had less weight gain or hypoglycemia.
Okay, so metformin looked quite favorable in this landmark study, and many subsequent studies have shown similar benefits. So it's not surprising that millions of people have taken metformin to treat their diabetes. Importantly for our listeners, does metformin improve cardiovascular outcomes?
Unfortunately, metformin has not been studied in a formal cardiovascular outcomes trial, unlike some of the newer therapies that we're using today. However, the collective evidence from clinical trials and observational studies is that metformin may have some cardiovascular benefit, and it's associated with reduced cardiovascular mortality compared to the sulfonylureas. In the UKPDS, metformin reduced the risk for myocardial infarction at the end of the intervention period, while sulfonylureas and insulin did not reduce risk until years later.
So can you summarize for us where metformin has traditionally fit into the pharmacologic treatment guidelines?
Until recent years, metformin, in addition to therapeutic lifestyle changes, has been considered to be first-line therapy for type 2 diabetes. Second-line therapy has then traditionally been chosen based upon other prevailing characteristics, such as cardiovascular or kidney disease, hypoglycemia risk, weight gain, and, of course, cost.
Okay, so that all seems very reasonable. So with the advent of newer therapeutic options, is metformin falling out of favor now?
No, not quite. In fact, when modest glucose reduction is the prominent indication for therapy, metformin is still pretty much the treatment of choice. In fact, the American Diabetes Association, or ADA, standards of care still emphasize that treatment decisions should be based upon person-centered factors such as treatment goals and preferences, comorbidities, potential for hypoglycemia or other adverse effects, and treatment burden. So this necessitates a shared decision-making approach, and in particular, it's important to address the social drivers of health.
Okay, so you really need to communicate with your patients, and there's so many things to consider. So what's changed exactly?
First of all, some newer classes of therapy not only lower glucose levels, but they independently reduce the risk for other important complications. Patients with atherosclerotic cardiovascular disease or CVD, heart failure, chronic kidney disease, and those patients in particular should preferentially receive therapies that address these comorbidities. Typically, a glucagon like peptide 1 or GLP 1 based therapy or a sodium glucose cotransporter 2, otherwise known as SGLT2 inhibitor, should be used. And then, if the glycemic goals are not met, metformin is a good second line or even third line treatment option.
All right, well, let's break this down a bit more. Do healthcare providers use either an SGLT2 inhibitor or GLP-1 based therapy for any of these indications, or does it depend on the clinical picture?
Well, let's start with heart failure. This is a common comorbidity among persons with type 2 diabetes. According to the recent ADA guidelines, SGLT2 inhibitors should be prescribed preferentially in persons with heart failure with reduced or with preserved ejection fraction. Many of these drugs are now indicated for treatment of heart failure, even in patients without diabetes. For patients with Ohio Medicaid or the Medicaid managed care plans, empagliflozin and dapagliflozin are preferred. Check out the show notes for a link to the Ohio Medicaid formulary. And then if additional glucose lowering is needed, a GLP-1 based therapy can be considered and may have additional symptomatic benefit in heart failure with preserved ejection fraction, at least for semaglutide and tirzepatide, for which the studies have been done. Otherwise, additional treatment can be considered based upon other compelling factors like efficacy, cost, or complexity. However, thiazolidinediones like pioglitazone should be avoided as it can increase the risk for heart failure or exacerbation, in part due to fluid retention. Although the mechanism isn't really understood, it's best to avoid saxagliptin and possibly alogliptin also due to the concern for increased risk of hospitalization for heart failure. These are dipeptidyl peptidase or DPP4 inhibitors. What's interesting is that other DPP4 inhibitors like sitagliptin and linagliptin are not associated with an increase in heart failure.
Okay, so there are a lot of considerations regarding heart failure. But what about patients with type 2 diabetes and atherosclerotic cardiovascular disease?
Well, in patients with known or high risk for atherosclerotic cardiovascular disease, either a GLP-1 based therapy or an SGLT2 inhibitor with established cardiovascular benefit may be prescribed. High risk is defined here as greater than or equal to 55 years of age with 2 additional risk factors. So that might include obesity, hypertension, smoking, dyslipidemia, and also albuminuria. Thus, it really applies to a large population of individuals with type 2 diabetes. In fact, in the REWIND study with dulaglutide, only 31% of participants had CVD at baseline, and there were reductions in major adverse CVD events regardless of baseline. For Ohio Medicaid recipients, both dulaglutide, a weekly injection, and liraglutide, once daily injection, are preferred. Recently, top-line results were released from the SURPASS CVOT, a long-term cardiovascular outcomes trial showing similar benefit of GLP-1s, tirzepatide, and dulaglutide on major adverse cardiovascular events. But tirzepatide had greater glycemic and weight loss efficacy, lower mortality, and better renal outcomes compared to dulaglutide. As with heart failure, both classes may be used when additional glucose lowering is needed.
Well, what about other comorbidities? What is the strategy for patients with chronic kidney disease, for example, and how exactly is it defined?
Great question. For this purpose, chronic kidney disease is defined as an estimated glomerular filtration rate, or EGFR, of less than 60. Or it could be albuminuria, which is a urine albumin to creatinine ratio of greater than 30. Additional renal protective therapy should be prescribed in addition to a maximally tolerated angiotensin converting enzyme, or ACE inhibitor, or angiotensin receptor blocker, or ARB. In this setting, an SGLT2 inhibitor or GLP-1 based therapy with proven renal benefit should be prescribed. As of this recording, the SGLT2 inhibitors empagliflozin, dapagliflozin, and canagliflozin have supportive evidence from dedicated renal outcome studies. It's important to note that glucose-lowering benefit is lost at the lower eGFR range, generally less than 45. However, in the case of renal and cardiac benefits, that is preserved even at lower eGFRs. And so as a result, you can use these drugs with eGFRs as low as 20. And in general, you should continue their use until dialysis is needed. Similar to the ACEs and ARBs, a small bump in creatinine can be observed. Might be around the range of 0.3 milligram per deciliter or 20%. And this should be tolerated without treatment interruption.
Okay, so there is proven renal benefit for SGLT2 inhibitors. Can the same be said for GLP-1 based therapy?
For GLP-1 based therapies, the FLOW trial used semaglutide once weekly. It's the only dedicated renal outcome study available among GLP-1s, and it demonstrated a significant reduction in composite outcome of major kidney-related events, including eGFR, end-stage renal disease, or death from kidney or cardiovascular causes. Other GLP-1-based therapies have demonstrated renal benefits, mostly reduction in proteinuria, when they're studied in larger cardiovascular outcome studies, however.
So, semaglutide has shown some favorable results on renal function, but there are so many drugs in each treatment class. They have the same mechanism of action, but do they have similar benefit?
Technically, no. There may be a class benefit, but not all drugs in each treatment class have demonstrated benefit for various outcomes in clinical trials, and some drugs in particular haven't been studied for all indications. Differences between the drugs in a class could arise from things like variations in receptor specificity, or there really could be a class effect that's obscured by differences in the population that's being studied or the study design. GLP-1 based therapies in particular have varying glucose lowering and weight loss efficacy, and that could be driving some of the differences in cardiovascular or renal outcomes. Even though the studies are designed to maintain similar risk factor management across treatment arms, small treatment differences may still persist due to their higher overall glycemic and weight loss efficacy compared to other therapies.
Okay, so in other words, the verdict is not yet in on these drugs as a class. As we know, both SGLT2 inhibitors and GLP-1 based therapies can be used for patients with CVD. I was curious, is there additive benefit to using both?
That's right, Craig. There definitely could be some additive benefit. And we know in particular that there is glycemic and weight loss benefit with additive use. The purported mechanisms for cardiovascular or renal outcomes are complementary, but it's not known for sure whether this really translates into reduced risk for cardiovascular or renal outcomes, as we just don't have the data. The dedicated clinical trials haven't been done. However, there are some supportive epidemiologic data and meta-analyses that support the potential for additive cardiovascular or renal benefits.
I was also curious, what about metabolic liver disease? Is there a preferred glucose lowering strategy?
Yes, GLP-1 based therapies are preferred. In particular, weekly semaglutide and tirzepatide show the best evidence so far. Semaglutide recently received an FDA indication for use in metabolic dysfunction-associated steatohepatitis, or MASH for short. And this was based upon the results of a phase 3 trial that showed that 63% of people treated with semaglutide at a 2.4 milligram dose had resolution of steatohepatitis with no worsening of fibrosis compared to 34% of people on placebo. So that was highly statistically significant. Dedicated MASH studies are underway for tirzepatide and for some other therapies. Pioglitazone has also shown some benefit for MASH. Listeners can check out Cardi-OH's podcast on MASH for details. We'll link it to the show notes.
Okay, but what if a patient doesn't have any of these comorbidities? Is metformin still the treatment of choice?
Well, that also depends. The most recent guidelines have highlighted not only glucose lowering efficacy, but also the weight loss goals. So again, a shared decision-making approach is needed. There will still be a lot of people for whom newer therapies are not affordable or not tolerated. And for most patients, metformin is still initiated first.
Okay, so how do other guidelines compare to this? Is there any consensus for all of this?
Great question. The ADA guidelines are updated annually and on a continual basis. However, there are other guidelines from specialty groups, including the American Association for Clinical Endocrinologists, or ACE, and the European Association for the Study of Diabetes, and they recommend a similar approach as the ADA. On the other hand, the American College of Physicians, or ACP, recommends metformin first line, and either an SGLT2 inhibitor or a GLP-1 based therapy second line based upon comorbidities that we already discussed. And this is because most studies showing cardiorenal or mortality benefit were conducted as add-on to usual care, and that typically included metformin. The ACP specifically recommended against routine use of DPP4 inhibitors second line because they don't demonstrate cardiorenal or mortality benefits. In addition, the ACP cites low certainty evidence suggesting that DPP4 inhibitors might be more expensive and less effective than sulfonylureas. The International Diabetes Federation recommends metformin first line and GLP-1 based therapies and SGLT2 inhibitors second line as part of an optimal care strategy, but it also acknowledges that it's not feasible in resource constrained environments.
Well, so Kathleen, are there situations where combination therapy should be initiated?
Yes, in fact, the ADA guidelines have emphasized the importance of achieving glycemic goals and avoiding clinical inertia. In the UK-PDS and other studies, achieving glucose goals early has a lasting impact on complications long term. This is called the legacy effect. In fact, some data suggests that the legacy effect begins as early as 1 year after diagnosis. And intriguingly, early treatment with combination therapy may reduce the risk of subsequent treatment failure. It's important to remember that only newer GLP-1 based therapies like dulaglutide, semaglutide, and tirzepatide, or insulin, or combination therapy are considered to have the highest efficacy in terms of glucose lowering. And because of this, the ADA recommends initial combination therapy, typically with metformin plus either a GLP-1 based therapy or an SGLT2 inhibitor for persons who are 1.5% or more above their A1C goal. And ACE recommends combination therapy for anyone with an A1C above 7.5%.
Well, I think it's worth highlighting that insulin used to hold the title for greatest glycemic efficacy among diabetes medications, but many GLP-1 based therapies result in equal or even superior A1C reductions compared to basal insulin.
Yes, that's correct. The American Diabetes Association recommends use of GLP-1 based therapies prior to starting insulin or intensifying insulin. There are situations where a patient might, however, really need insulin first, such as those with severe hyperglycemia or who are markedly symptomatic, or potentially who might have type 1 diabetes. However, a GLP-1 based therapy should be considered either sequentially or in tandem, and in some cases, insulin can eventually be discontinued.
So, Kathleen, you mentioned previously that the ADA emphasizes both glycemic and weight loss efficacy in considering choice of therapy. Are we talking about the same agents here?
No, actually, only semaglutide and tirzepatide are considered to have the highest weight loss efficacy. Weight loss with dulaglutide and liraglutide is considered to be high, and other GLP-1 based therapies and SGLT2 inhibitors are considered moderate. Metformin is considered to be weight neutral.
Okay, so what if your patient responds well to treatment? When can they stop it?
Well, something that's not widely appreciated is that diabetes is a progressive disease. As a result, one of the pillars of treatment is not only achieving, but maintaining those goals of therapy. In the National Institutes of Health GRADE study, 5,000 participants who were initially controlled on metformin monotherapy were randomized to one of 4 treatment groups. That includes glargine, liraglutide, glimepiride, and sitagliptin. And treatment failure rates were highest with glimepiride and sitagliptin. Glargine and liraglutide were statistically better than the other medications in this regard, but A1Cs worsened substantially in all groups over the 5-year follow-up period. It's not yet known how outcomes may change with some of the newer, highest efficacy GLP-1 based therapies or with SGLT2 inhibitors because they weren't included in the studies. Therefore, I would consider de-escalation, but not stop therapy entirely in the majority of individuals due to the serious concern for relapse and risk for complications. Again, you would need to employ a shared decision-making approach.
That's a really interesting study and very helpful advice. So, what about those individuals who cannot afford newer therapies?
Yes, when cost is a major concern, consider pharmaceutical discount programs, formulary alternatives, referrals to social work or pharmacy, and less expensive options where appropriate. And in that case, I would engage patients in shared decision making discussions about the limitations of these therapies, including potential for weight gain, hypoglycemia, and also the durability of the effect. At the same time, we can emphasize the value of glycemic control for reducing microvascular complications. As remember, the UKPDS was able to demonstrate benefit compared to therapeutic lifestyle changes alone using low cost medications. And for these individuals, it's especially important to consider social drivers of health during shared decision making. For instance, low socioeconomic status is associated with poor glycemic control due to cost related non adherence and limited access to healthy food or spaces for exercise. Additionally, storage of insulin and most GLP-1 based therapies, which require some refrigeration, may be impractical in patients with unstable housing or lacking consistent access to utilities. Disabilities are common, and those with limited dexterity, such as after a stroke, might struggle with self injection. And then cognitive impairment and lack of social support needed to manage complex regimens may also be limiting factors.
Well, thank you, Kathleen, for shedding light on such a complex subject. Do you have any final comments for our listeners?
Yes, I want to emphasize the central role of healthy lifestyle behaviors to the success of any glucose lowering regimen. In addition, a referral to diabetes self management, education, and support should be considered not only at the time of diagnosis, but also on an annual basis, especially if a patient is not meeting their treatment goals. If there are changes in treatment, such as initiation of insulin, when complications arise, or during important life transitions, such as during pediatric to adult care, pregnancies, or after hospitalizations. So, to sum up, while metformin is still considered first line therapy for many people, it's important to take into account major comorbidities, the glycemic and weight loss goals, and other factors which should be considered when selecting a treatment plan. And a shared decision making approach is always needed.
Well, thank you so much, Kathleen, for speaking with me today.
It was great to be here.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.